Good morning. Today we're going to discuss about the fungal infections of skin and subcutaneous tissue. So here we are going to deal about on the introduction, classification, outline in briefs of the superficial fungal infection like pityriasis versicolor or Pittosporum folliculitis, dermatophytosis, candidiasis, and outline in brief about deep fungal infections like mycetoma, chromoblastomycosis, sporotrichosis, rhinosporidiosis, cryptococcosis, histoplasmosis, and blastomycosis. As you see here, you can view the microscopic picture of fungi, and here what are you seeing? These linear things are known as the hyphae of the fungus. And this is the hyphae and the spore. See, this linearly arranged things are nothing but the hyphae of the fungus, and these circular or annular grouped things are known as the spores, which are essential for the fungal reproduction. Coming to the classification of fungal skin infections, it can be divided into superficial fungal infections, which is confined to the stratum corneum. So stratum corneum is the topmost layer of the skin and the epidermis. So that is when the fungal infections are only confined to the stratum corneum, we call it as a superficial fungal infections. For example, pityriasis versicolor or Pittosporum folliculitis, dermatophytosis, and candidiasis. Now, the deep fungal infections, they invade the deeper tissues, and such deep infections are mycetoma, chromoblastomycosis, and sporotrichosis. Coming to systemic fungal infections, which are cryptococcosis, histoplasmosis, and blastomycosis, and the opportunistic fungal infections, which means those fungal infections which are affected in the immunocompromised patients like diabetes mellitus or HIV are cryptococcosis, candidiasis, and mucormycosis. Now, few words about the superficial fungal infections. So these superficial fungal infections, they mainly affect the skin, hair, nails, and mucous membrane. And the agents are Malassezia furfur, which can cause pityriasis versicolor or Pittosporum folliculitis, so which is caused by the fungus Malassezia furfur. Now, three species of dermatophytes are the most common, and they are Microsporum, Trichophyton, and Epidermophyton. And these three can cause a ringworm, also known as the tinea infection, which is more common in our OPDs. Next is Candida albicans, which can cause candidiasis of the skin, mucous membrane, as well as the nails. Coming to something about the diagnosis, it is mostly diagnosed by the fungal infections are mostly diagnosed by clinical examination alone. And for confirmation, we need to know we need to do skin scraping and nail clipping using KOH or the potassium hydroxide smear under microscope. Next is fungal culture we can do to know the species. Then wood slamp examination. Wood slamp is nothing but it can emit. It's a device which emits 365 nanometers of blue light, which is absorbed by the particular fungus or the bacteria or whatever the organism, and it will reflect back a certain color of a particular wavelength. So according to that, we can know which species or which infection is that. We can diagnose this better. Then also we can do biopsy for a deeper mycosis. Now, other tests for predisposing factors, like we have to rule out diabetes mellitus. Next, like extensive and recurrent fungal infections can indicate an underlying disease like diabetes or HIV. That is an like immunocompromised people. Now, choice of antifungal depends on the extent or the depth of the lesions together with the recurrence and presence of underlying predisposing factor. This is a picture of tinea versicolor where you can see multiple hypopigmented macules which are seen discrete as well as which coalesce together to form a macule. And here you can see some scales also. So the main thing of tinea versicolor is that brany scales or fine scales will be present. So that scales will be more evident when you stretch the skin. That's why it is known as fine scales or brany scales. Coming to superficial fungal infection in detail, there is Tinea versicolor. It's a common fungal infection of skin in warm and humid tropical climate. It is caused by Malassezia furfur or Pittosporum, which was named as earlier. Now, recently it is also caused by Malassezia globosa. These organisms are part of the normal skin flora only, and it can produce color changes when beyond a normal level or beyond an extensive level is present. Now, clinically, there is hypo or hyperpigmented macules with fine briny scales, that means the powdery scales, which become coalesce to map-like patterns, well-defined, multiple, and it is usually asymptomatic. Tinea versicolor has unique feature like either hyper or hyperpigmented lesion, and hence its name versicolor, because it can be of any color, either hyperpigmented or hypopigmented. Commonly, the tinea versicolor lesions you can see in the upper trunk, then also the face, flexural areas, and it usually occurs in the young adult male and usually associated with people having more sweating, that is hyperhidrosis or diabetes mellitus. How will you diagnose tinea versicolor? The clinical features are characteristic, and then you can do scraping with potassium hydroxide, which shows positive yeast and hyphae. Wood slime can show golden yellow fluorescence, and then you can do culture also for the Malassezia globosa or furfur. Now, what are the differentials for tinea versicolor? As soon as you see hypopigmented macule in a patient, what all things can come to your mind as a differential diagnosis? And that includes vitiligo, where you can see hypo as well as mainly deep pigmented patches on the skin of the patient. Next, erythrasma, which commonly occurs as in the skin fold as a hyperpigmented lesions, and that is erythrasma is actually a bacterial infection which is caused by Corynebacterium minutissimum. And then pityriasis rosea is another differential. Next, you can tell secondary syphilis, because it is a great imitator of almost like a lot of diseases. So syphilis can mimic, it has a varied picture, so it mimics a lot of differentials in dermatology. Now, the next differential of pityriasis versicolor is seborrheic dermatitis. Next is pityriasis alba, which usually occurs as hypopigmented macules on the face of children. Then you can also include indeterminate Hansen's disease or leprosy. Now, what is the treatment of tinea versicolor? You can use both topical and systemic antifungals, and the choice depend on the extent of the lesion, how extent the lesion is present, as well as how recurrently the patient is presenting with the disease. So you can give sodium hyposulfite lotion or sodium thiosulfite 20%, which can be applied twice daily for 3 to 4 weeks. For about a month, you can give sodium hyposulfite lotion or sodium thiosulfate. Next is antifungal cream or solutions like imidazole, which is an antifungal one. You can give for 2 weeks, or cyclopirox shampoo you can give for 2 weeks. And the systemic therapy like ketoconazole 200 mg daily for 5 to 10 days, or a tablet fluconazole 400 mg a single dose, stat dose is sufficient. So systemically what you can give is tablet ketoconazole or fluconazole. What is the dose of ketoconazole? Ketoconazole 200 mg daily for 5 to 10 days, or you can give fluconazole 400 mg stat dose. Now, for recurrent antifungal infection, for recurrent tinea versicolor, you can give antifungal soaps also, like ketoconazole soap. The pigments will persist for weeks or months after the disease is cured. Pityriasporum folliculitis. It is due to Malassezia infection of the hair follicles. Clinically, there will be perifollicular erythematous papules or pustules, which mimics like bacterial folliculitis. So the main site of Pityriasporum folliculitis is back, chest, and extremities. The predisposing factors are diabetes, high humidity, use of steroids, antibiotics, and immunosuppressant drugs. How can you diagnose? It is by main thing is clinical features are only the characteristic, and Wood's lab examination as well as potassium hydroxide smear also helps in diagnosis. Treatment is similar to tinea versicolor, where you can give topical as well as systemic antifungals. Coming to dermatophytosis, that is ringworm or tinea. This mycosis caused by dermatophytes called as dermatophytosis. Now, the etiology is the common infection in tropical hot and humid climates. There are 3 species of dermatophytes, and in that microsporum, it mainly affects the skin and hair. Now, trichophyton, it affects skin, hair, and nail. For an easy purpose, tri means 3, so it can affect skin, hair, as well as nails. And epidermophyton, which affect the skin and the nail. So skin is a common factor for all these 3 dermatophytes. Then it is a highly keratinophilic organism, and they grow in the keratin of the stratum corneum, or the topmost layer, and they can be acquired from soil, humans, as well as animals. The predisposing factors are heat and humidity. So whenever there is a summer, like in the summer season, the tinea infection will flare up or is precipitated. Next is poor nutrition and hygiene, and then contact with the infected animals or fomites. Now, Trichophyton rubrum is by the most common dermatophyte responsible for tinea. So usually tinea is caused by the most common organism, Trichophyton rubrum. Now, diabetics and HIV are prone to develop extensive, recurrent, as well as atypical forms. So there is a typical form for tinea where there will be annular, hyperpigmented, scaly plaques, which is well defined. But this typical form will be gone, and there will be an atypical presentation in those who are having like diabetics or HIV or such immunocompromised conditions. Dermatophyte infections of human origin evoke immune response by a delayed hypersensitivity, that is type 4 hypersensitivity reaction, whereas most fungi of the animals and soil origin evoke cell-mediated response leading to inflammatory lesion. So the dermatophytes infection of human origin, they evoke a delayed hypersensitivity reaction, as well as a fungus. When the fungus of animal and soil origin, they can produce a cell-mediated immune response. Clinical features, like the fungal infection due to dermatophytes can be classified as depending on the site of the involvement. The first classification is according to the site of involvement. It can be when it is present in the trunk, we call it as tinea corporis. Now in the face, tinea faciae. In the scalp, tinea capitis. In the palms, tinea manum. In the groin region, it is tinea cruris. In the beard area, it is tinea barbae. Then in the athlete's foot, in the foot, we call it as tinea pedis. In the finger and toenails, we call as tinea unguum. So depending on the what site the tinea has caused the infection, we call it as 8 different names. So that is tinea corporis in the trunk, tinea fascia in the face, tinea capitis in the scalp, tinea manum in the palms. Then in the groin, we call as tinea cruris. In the beard, it is tinea barbae. Foot, tinea pedis, and finger and toenails you call as tinea unguum. Now the second classification is steroid modified tinea, which is known as tinea incognito. Now due to hypersensitivity to dermatophyte, we call as dermatophytitis. Although some morphological variation, the classic lesion has an annular pattern and hence the name ringworm. So even though there are some morphological variations present, usually the typical form is an annular plaque, and that's why it is known as a ringworm infection. See, this is the diagram of tinea corporis. Here you can see multiple erythematous annular plaques with scaling. So this is an example of tinea corporis which occurs in the body, in the trunk area. Now this is the picture of tinea fasciae, where you can see the erythematous annular plaque with a central clearing and a peripheral erythematous border. So usually the tinea lesions will have a central clearing. Okay. Now this is the picture of tinea cruris, which which include annular, erythematous, well-defined plaque with a central clearing and a border of different papules which are coalesced together. So there is a central clearing, and it's an annular lesion which is well defined, which is present in the groin area, which we call as tinea cruris. Now, this is tinea manum, which involves the palms of the patient, and here you can see extensive scaling. Now, tinea corporis, it's a dermatophyte infection of the non-hair-bearing skin of the body. It's a common infection with the trichophyton rubrum. Typically, the lesion begins with pruritic, erythematous, scaly patch or plaque, and the lesion spread peripherally with a central clearing with pigmentation and becomes annular in shape, and it can be single or multiple lesions will be present. Now, tinea imbricata is a rare variant characterized by scaly plaques arranged in concentric rings caused by Trichophyton concentricum. So, it is also known as tinea circinata. So, tinea imbricata or circinata, it is like you can see multiple annular rings. Now, the differential is pityriasis rosea, circinate impetigo, annular psoriasis, nummular eczema or discoid eczema. So, these lesions can be confused with tinea corporis. So, what are the differentials? Pityriasis rosea, circinate impetigo, annular psoriasis, and nummular eczema. Now, tinea incognito. What is tinea incognito? It is the name given to a dermatophytic infection where the typical clinical appearance is altered by inappropriate treatment, usually a topical steroid, because the steroids, they will mask the features of tinea. Because what steroid will do, what is the mechanism of action of steroid is that it is anti-inflammatory in nature, and it will suppress our immunity so that all the erythema, redness and everything will subside, but it won't actually kill the fungus. Now, incognito has less raised margin, it is lesser scaly, it is more pustular and tends to be more extensive compared with untreated tinea corporis. Tinea cruris is most common type in India, and it is like the most common in men than women. Usually it occurs bilaterally symmetrical. The lesion often extend into the gluteal fold and the buttocks. Lesion is similar to tinea corporis, and it is often referred to as Daubich. So, cruris, the tinea cruris, which occurs in the groin area, is also known as Daubich. It affects the skin folds, especially the groin in males. Tinea fasciae, it is characterized by, again, erythematous scaly patch or annular, or it can be circinate shiny lesion also on the face. There can be intensive itching, burning, and exacerbation after sun exposure, which means there is a photosensitivity factor also. Now, tinea barbae, also known as tinea psychosis. It is due to the invasion of coarse hair, and there will be clinically superficial pustules surrounding the hair follicles. It is associated with oozing, and crusting will be seen. Crusts are nothing but, we call it a scab. So crust is nothing but the dried up exudates. Now, hair tends to easily pluckable, like lusterless and easily pluckable hair. It occurs on the beard and the moustache area. So that's why it is known as tinea barbae or tinea psychosis. This is tinea capitis, and that is like the black dog type. There are different forms also. So this is the black dog type of tinea capitis. You can see several black dots, and this is actually non-inflammatory type. This is again another picture of tinea capitis, which is the inflammatory type, and this you can see extensive scaling is present. No, so you can confuse it with even scalp psoriasis. So this is tinea capitis, which is the inflammatory type, and this variant is known as favus. So from this you can understand that two types are there. Three types are there. We'll come to it. Even Kirion is also there. So favus, which occurs in the tinea capitis, it's an inflammatory type where you can see scaling also. And the black dot type, which is a non-inflammatory type. And the third one, which affect the capitis, is again Kirion. So this is again an example of inflammatory type. So Kirion, favus, both are inflammatory type, which occurs in the capitis, in the scalp. And black dot type is a non-inflammatory type. So tinea capitis can be manifested in three forms. It can be a Kirion, it can be a favus, or it can be black dot type. Next, tinea capitis. It is common in young boys, no symptoms but only mild scaling will be present. Hair can be infected with trichophyton and microsporum, as we have discussed earlier. Now, the type of infection in the hair, it can be ectothrix or endothrix. Ectothrix means usually it is by Microsporum canis. So ectothrix means which include the outside of the hair follicle, hair shaft. So it is caused by Microsporum canis. Infection is both inside as well as outside of the hair shaft, that is ectothrix. And endothrix is mainly caused by tonsurens, Trichophyton tonsurens. And the infection is only present inside the hair shaft, and that is the main difference. Now, clinically, the types of tinea capitis can be non-inflammatory as well as inflammatory. Among non-inflammatory, there can be dry scaling, which resembles that of dandruff. Now, black dots, like the hair breaks at the surface of the scalp. Now, gray patch, where the hair breaks close to the surface, and there is a scalp skin scaling. So, in the non-inflammatory tinea capitis, either they can be dry scaling, then they can be black dot, where the hair breaks at the surface of the scalp. Now, gray patch means it is not at the surface, but the hair breaks close to the surface of the scalp. Inflammatory tinea capitis can be chirion or favus. In contrast to the non-inflammatory types of tinea capitis, inflammatory types heals with scarring alopecia. So always the inflammatory types, it will heals with scarring. Next, chirion. It is the most inflammatory form of tinea capitis, and it is often of animal origin. It is caused by Trichophyton verrucosum and Trichophyton mendagrophytes. So, chirion, the most common animal origin form of tinea capitis, which is of inflammatory type and heals by scarring alopecia. It is caused by Trichophyton verrucosum and Trichophyton mendagrophytes. It is characterized by wet, purulent, boggy, painful swelling with nodules or plaques, which I have shown you before. So it will be how will be the lesion in chirion is that there will be wet, purulent, boggy, painful swelling with pustules, nodules or plaques. The hair fall out or are easily pulled out without pain and may heal with scarring. The differentials are cellulitis or furunculosis of the scalp. So the differentials of chirion is cellulitis or furunculosis. Now coming to favus. Favus is another inflammatory type of tinea capitis which also heals by scarring. It is the most common in the remote area in the Central East Africa. Classically, it results in honeycomb style destruction of the hair shaft, which is caused by Trichophyton scholini infection. The patches of redness and scaling with a disc or cup-shaped yellow crust or scutula is present. So what is scutula? It is patches of redness and scaling with a disc or cup-shaped yellow crest. A fetid odor can be present for favus. Later, atrophic patches develops, which causes permanent alopecia. And here the differential is impetigo or ecthyma or seborrheic dermatitis because of that scaling. For chirion, we have differentials as cellulitis or furunculosis, and favus, the differential is impetigo, ecthyma, or seborrheic dermatitis. Now, diagnosis of tinea capitis. How will you diagnose? The clinical features are only the characteristic. Now, Wood's lamp examination for tinea capitis shows greenish fluorescence. Greenish fluorescence. We studied that yellow fluorescence is shown by tinea versicolor, and for tinea capitis, it is Wood's lamp shows greenish fluorescence. Now, the KOH mount about 10 to 30%, it helps in the diagnosis. Anthrospores of the fungus are seen outside. If the spores are seen outside, it is ectothrix type, and if it is seen inside, that is the anthrospore is seen inside, it is endothrix type. In the culture or the SDA, we can use Sabron's dextrons agar, we can use for the confirmation of the diagnosis. The radiopharynx type of tinea capitis include like gray patch, it is seborrheic dermatitis, PS, and atopic dermatitis, that is scalp psoriasis or atopic dermatitis. Black dot can be again seborrheic dermatitis, PS, atopic dermatitis, lichen planus and alopecia areata. Now for chirion, we have cellulitis or furunculosis, and favus, as we told now, impetigo, ecthyma and seborrheic dermatitis. These are the different differentials. So this is a picture of tinea pedis or athlete's foot, tinea pedis. So here you can see a well-defined scaly erythematous plaque on the foot. This is again another picture of athlete's foot or tinea pedis. So tinea pedis, it is mostly bilateral and the recurrence is very common. The commonest agent which causes tinea pedis is tinea rubrum and epidermophyton floccosum. So tinea rubrum and epidermophyton floccosum. In the hair, it was microsporum and trichophyton, and in the tinea pedis or the skin, that is trichophyton and epidermophyton. Usually acquired by infected socks, shoes, games kit, or towels. There are 4 clinical types for athlete's foot. That is interdigital type, which is the most common. Then vesicular type on the side of the toe. On the side of the toe, you can see some vesicles, that is raised lesions with a fluid content of less than 0.5 centimeter. So the third one is hyperkeratotic type, which is thickened and scales on the side of the toe, and then moccasin type. So the 4 types of tinea pedis are: one is interdigital, which are seen in between the digits, or the vesicular type, or the hyperkeratotic type, where you can see thickened scales, or moccasin type. Now, interdigital type, the skin between the toes are affected here, especially the 4th and the 5th, and there will be a sodden, white and macerated appearance, which will looks like a candidiasis. This is nothing but tinea unguum, that is the tinea infection which involves the nails. Tinea unguum or onychomycosis, we can tell. Tinea unguum or onychomycosis. It is an infection of the nail by dermatophytes and is termed as tinea unguum. 90% of the fungal infections of nail are caused by dermatophytes. And what is the main causative organism? That is tinea rubrum. It is also caused by yeast like candida and molds. So this tinea infection will be insidious in onset and it progresses to complete nail dystrophy. So this tinea infection of the nails, which mainly caused by 90% of the fungal infections of the nail are caused by tinea only, like dermatophytes, and it can also be caused by yeast like candida and the molds, and it will be gradual onset and gradually progress, insidious onset and gradually progressing, which will at last lead to the nail dystrophy. Types on the site of the nail involvement and depth. So it can be distal subungual onychomycosis when it is present at the end of the nail lift up. Next, proximal onychomycosis. Here you can see yellow spots half of the nail. Okay, yellow spots on the half of the nail you can see in proximal. Then white superficial onychomycosis, where you can see flaky whitened pits on the top of the nail pits. Then total dystrophic onychomycosis, when there is a complete dystrophy of nail plates. Then lateral onychomycosis, where there is white or yellow discoloration only on one side of the nail. Commonly starts as distal and lateral subungual onychomycosis and progress to nail dystrophy. So the main presentation is it starts as distal or lateral subungual onychomycosis, which will lead to complete nail dystrophy. Candidal onychomycosis usually starts as the nail fold infection like paronychia in the cuticular area. And the differentials for this nail involvement is it can mimic psoriasis, lichen planus, and eczema. So in these conditions also you can see nail problems. And this is nothing but oral candidiasis, where you can see that curdy white flax or plaques which are seen on the dorsum of the tongue. This is nothing but groin candidiasis, where you can see erythema as well as some multiple papules which has coalesced together to form a plaque, and there is a macerated appearance. Candidiasis or candidal infection. So the skin, nails, mucous membranes can be affected by Candida albicans. So Candida albicans can include the skin, the nails, and the mucous membranes. Predisposing factors are infancy, old age, occlusion with diapers, humid climate, antibiotics, immunosuppressive medication, and internal malignancies, malnutrition, pregnancy, diabetes mellitus, Cushing syndrome, and HIV. So all this can be a precipitating factor. Clinical patterns. First one, oral candidiasis or oral thrush. There are 4 types due to the underlying predisposing conditions like HIV, antibiotics, use of antibiotics, or smoking. So oral candidiasis can be caused by smoking or in HIV patients, or use of antibiotics. The types are acute. When there is an acute manifestation, there will be creamy, curd, whitish pseudomembranous patch on the buccal mucosa, gums, and palate. In the chronic type, there will be atrophic lesion resembling leukoplakia. Chronic type, you can see atrophic lesion. And acute one, you can see creamy curd-like pattern. Then rhomboid glossitis, a diamond-shaped inflammation seen at the posterior part of the tongue. That is rhomboid glossitis. So rhomboid glossitis also is one of the type. Next is angular cheilitis, where you can see fissuring and maceration over the ankle of the mouth with bacterial co-infection also. So what are the 4 types of oral candidiasis? That is acute presentation. It can be acute with a curdy precipitate. Then chronic, when there is atrophic lesion resembling leukoplakia, angular cheilitis with fissuring and maceration over the angle of mouth with secondary bacterial infection, and rhomboid glossitis, which is present as a diamond-shaped inflammation on the posterior part of the tongue. Next, second one is intertrigocandidiasis, also known as flexural candidiasis, which occurs mainly in the skin folds, that is in the axilla, the skin fold, the inframammary area, as well as the groin area. So any inflammation opposing the skin surface, which are most commonly in the obese patients, and the lesions are erythematous, papules, and maceration can be seen. Candidal balanoposthitis, which is the candidal infection in the glands and the prepuce of the male. So it can present as small papules or vesicles and pustules or persistent erosion with maceration and radial fissuring seen on the glans penis. Exacerbation following intercourse always seen in uncircumscribed men, and it may be complicated by diabetes mellitus. Now, candidal vulvovaginitis. So 1/3 of the total vulvovaginitis cases are caused by candida only, and there will be curdy white vaginal discharge on examination with erythema, and it is uncommon in the prepubertal girls. Symptoms like pruritus, soreness will be present, and painful intercourse is the factor. Now, paronychia and candidal onychomycosis. So the next one is paronychia and candidal onychomycosis, which involves the nails. It is characterized by loss of the nail cuticle with inflammation in the nail folds. While acute paronychia is usually caused by bacteria, candida is a major cause for chronic paronychia. So fungal infection of the nails is chronic, and bacterial infection of the nail is acute. So the candida is a major cause for chronic paronychia, which in turn may progress to onychomycosis. Now, chronic mucocutaneous candidiasis also is a type. So there are 6 types. Now, investigation like smearing with potassium hydroxide, it shows budding yeast cells and pseudo hyphae. Culture, you can do culture to confirm the diagnosis. Next, other tests for the predisposing factors like diabetes mellitus have to be ruled out. Treatment of fungal infection. The aim of treatment is to reduce the morbidity and thereby to prevent the recurrence as well as the complications. The choice of antifungus depends on the extent or depth of the lesions and how recurrently it is presenting in the patient as well as the underlying predisposing factors. Now, the general measures are elimination of the moisture is very essential. So you have to strictly tell the patient to avoid the wet reason like wet area, or you have to tell that you should be you have to tell the patient to keep always dry the lesions, or wherever the skin folds, it have to be kept dry. Then open footwear or bath for tinea cruris or pedis to avoid sharing of the combs and headwear of tinea capitis. So we should not share like personal things like our chappals or our caps, something like that. So it can also precipitate tinea, or it can also spread the tinea infection from one person to another. Next, coming to the treatment, topical therapy is by creams, gels, lotions, powders for the localized lesions. So topical therapy for localized lesions are preferred. Like you can give either imidazole group or allyl amine groups are present. Among the imidazole, you can use clotrimazole, miconazole, ketoconazole, eberconazole, iconazole, fluconazole, etc. So these are the azole groups, and allyl amines like terbinafine, butanafine, amorolfine. Allyl amine group is terbinafine, butanafine, amorolfine. Imidazole group is clotrimazole, miconazole, ketoconazole, eberconazole, iconazole, fluconazole, and miconazole. Now, other agents like cyclopyroxalamine can be advised. Amorolfine and cyclopyrox can be impregnated nail lacquers are also good in tinea anguum. For the tinea anguum or the tinea nail infections, the lacquer, that means like nail polish, you can apply the antifungal creams. And lacquer formulations are present for cyclopyrox and amorolfine. Systemic therapy. Systemic antifungals are given for extensive or refractory to topical treatment or treatment for onychomycosis, which needs more time of treatment, and tinea capitis. For tinea capitis, for nail infections or onychomycosis, or for recurrence or refractory thing, you can give systemic therapy. Like griseofulvin, 250 mg twice daily can be given for tinea capitis. Griseofulvin, 250 mg twice daily for tinea capitis. Now, fluconazole you can give 150 mg weekly or 50 mg once daily. So, fluconazole 150 mg weekly or 50 mg once daily can be given. Now, terbinafine 250 mg once daily, or itraconazole you can give 100 or 200 mg once daily, or pulse therapy monthly once for 7 days, like 3 doses you can give. So how is pulse therapy itraconazole? You can give pulse therapy monthly, like once for 7 days, every 7 days. Now that means every 1 week you can give 200 mg itraconazole, or you can give 100 or 200 mg itraconazole once daily. Or pulse therapy means you can give every 7 days, like 3 doses you can give pulse therapy. Now, duration of treatment for systemic antifungals. For tinea corporis, you should give for 4 to 6 weeks, about 1 to 1.5 months. For tinea cruris, 2 to 4 weeks are sufficient. For fasciae, it is 4 weeks. Capitis, it is 6 to 8 weeks, as well as for tinea pedis and manum. So tinea pedis, manum, and tinea capitis, it takes 6 to 8 weeks. Tinea angum, it takes 4 to 8 months. So the onychomycosis or the nail thing, it needs therapy for a longer duration, that is about 4 to 8 months. A shorter duration of treatment is needed with terbinafine and itraconazole and used as pulse therapy in case of an onychomycosis. Pulse therapy means like every every 7 days you can give the dose of itraconazole or terbinafine. For itraconazole. Now, griseofulvin 15 to 20 mg per kg is now mainly in tinea capitis in children. So now we will give tinea capitis in children. For the tinea capitis in children, we give griseofulvin 15 to 20 mg per kg. Uncommon superficial cutaneous fungal infections like tinea nigra, it is usually caused by H. wernicki, characterized by brown to black well-defined macule on the palms, resembling silver nitrate or India ink stains, rarely multiple and plantar lesions, effective by imidazole, allyl amines, cyclopyrox. Next is pedra or stone. Pedra means stone in Spanish. It is a fungal infection of the hair shaft. It is characterized by small nodules attached to the hair shaft. There are two types, black pedra, white pedra. Black pedra characterized by firmly attached dark pigmented nodules affecting the scalp hair caused by Pedria horte. Now, white pedra characterized by loosely attached light pigmented nodules affecting the scalp, beard, axillary, and pubic hair caused by Trichosporin asahi. Shaving hair is treatment of choice, and systemic terbinafine for black pedra, whereas topical azoles can be given for white pedra. And this is the picture of mycetoma. It's again a fungal infection. Deep or subcutaneous mycosis, mycetoma or Madura foot. It is a deep fungal infection characterized by clinical triad of swelling, discharging sinuses, and discharge containing granules. Commonly occur on the foot, hence called Madura foot. There are two types, true fungal infection or eumycetoma and similar infection by a filamentous bacteria called as actinomycosis. So there are two types of mycosis. which is when it is caused by true fungus, it can be eumycetoma. It can be called as eumycetoma, and if it is a filamentous bacteria, it can be actinomycosis. So it is characterized by formation of macroscopic or microscopic aggregates of fungal or actinomyces filaments, which are termed as grains. So this grains contains nothing but aggregates of the fungal or actinomycin filaments. Etiology and pathogenesis: the eumycetomas are seen worldwide, commonly in the rural area, usually among the agricultural workers who work barefoot. Organism normally present in the soil or dust, and infection occur after minor penetrating skin injury inoculating the soil organisms. In most of the cases, organisms are introduced through injuries by thorns or wood splinters. Important species causing mycetomas are: eumycetoma is caused by Madurella mycetomatis. Madurella mycetomatis, which causes eumycetoma. Actinomycotic caused by Streptomyces somaliensis, which is a bacteria. So Streptomyces somaliensis causes actinomycotic infection. Also, it is caused by Actina madura madure and Nocardia brasiliensis, which is the most common. So eumycetoma is by Madura mycelomatis, and actinomycosis is caused by Streptomycosis somaliensis, Nocardia brasiliensis, and Actinomadura madure. Clinical features: both the type present as progressive cutaneous and subcutaneous swelling with multiple nodules which develop suppuration and drains into sinus, discharging pus and discharging grains during active stage of the disease. So during the active stage of the disease, you can see erythema with like swelling, multiple nodules with discharging sinus and pus and discharging grains. Feet and the lower leg are common site, like 70 to 85%, and also it can happen in the neck, trunk also. Bone involvement may lead to osteomyelitis of the bone and deformities. Now, the incubation period varies from few weeks to several years. Clinical triad consists of an indurated tumid swelling, presence of discharging pus from the sinus, and discharge of grains from the sinus. So there can be an indurated, a thickened swelling present, and there will be like discharging sinus, like discharging pus from the sinus, and also discharging grains from the sinus. Grains are nothing but it contains fungal filaments and the grains, fungal filaments and the contents of the fungus. Now, diagnosis: discharge of the grains and color of the grain give idea about the diagnosis. Confirmation you can do by keloid smear and culture. Skin biopsy shows abscess collection with extensive granulation tissue on eosinophilic club-like material may border the granules. X-ray to rule out deeper involvement and osteomyelitis can be done. Eumycetomas and actinomycetoma, how is the difference? Eumycetomas are when it is caused by the fungus Madura mycelomatis. It is slowly invasive, but actinomycetes, which is caused by Nocardia or Streptomyces, it will be a rapid growth. So fungus is a chronic growth, a slow growth. Now, in eumycetoma, there will be late presentation, which is asymptomatic. Actinomycosis, there will be early presentation. Eumycetoma, there is no pus or there will be only few sinus. Actinomycetoma, there will be pus present and sinus will be numerous in amount. Now, the granules will be blackish brown and 4 to 5 microns in diameter. Now, actinomycetoma means they will be single. The granules will be yellowish white and less than 1 micron size. So, in eumycetoma, it will be larger diameter with a blackish brown granules. But when the granules are very yellowish white color and they will be present as single or less than 1 micron, it is actinomycetoma. Now, in eumycetoma, you see more deformity, but in actinomycosis, it is lesser deformity. And gram stain will be negative in eumycetoma, but it will be positive in actinomycetoma. Treatment: both the types, eumycetoma and actinomycetoma, the treatment range from 3 to 12 months. For eumycetoma, in most of the cases, unresponsive to antifungal, you can do radical surgical removal. Systemic antifungals like itraconazole or ketoconazole or terbinafine is used as an adjunctive therapy. For actinomycosis, medical treatment is usually effective. Single or combination with injection streptomycin or injection amikacin, clotrimazole, dapsone, rifampicin, or isoniazid or oral penicillin can be given. Surgical debridement may be required for abscess. Abscess, if present, should be always drained out. Uncommon subcutaneous and systemic mycosis are chromoblastomycosis. Like it is characterized by verrucous, warty, papules, and plaques on exposed areas of limbs. Sporotrichosis, the four types are cutaneous or lymphocutaneous or pulmonary or osteo, articular, and disseminated sporotrichosis. Rhinosporidiosis, clinically vascular friable polyps from nasal mucosa and skin lesions and papillomas, which will be verrucous in nature. Now, cryptococcosis, caused by Cryptococcus neoformans, that is an encapsulated yeast. Primary cutaneous cryptococcosis is transmitted through pigeon droppings and present as solitary nodules with secondary ulceration and associated lymphadenopathy will be present. Disseminated cryptococcosis is seen in immunocompromised patients. So the uncommon subcutaneous and systemic mycosis are nothing but chromoblastomycosis, rhinosporidiosis, cryptococcosis, and sporotrichosis. The classical lesions are molluscum contagiosum like umbilicated papule which develop a central H crust. Diagnosis confirmed by staining a drop of serum with Indian ink to demonstrate the capsule. So that is about cryptococcosis. Diagnosis is by Indian ink staining. Histoplasmosis, it is caused by Histoplasma capsulatum found in the soil of bird droppings. Cutaneous lesions includes erythema nodosum like lesion, erythema multiforme like lesion, multi-system involvement like bone marrow, liver, spleen, and lungs. Now, blastomycosis. There will be a characteristic granulomatous and suppurative mycosis which affect the skin, lungs, bone, and brain, which is caused by blastomyces dermatitis. And this is a picture of sporotrichosis where you can see multiple nodules and plaques, which are erythematous. This is a picture of chromoblastomycosis. And this is the picture of blastomycosis where you can see multiple nodules and crust are present on the nodules and plaques. So that's all about fungal infections. Thank you.